Hey, Jeff, good morning. I'm good. How are you?
Rob Alsop.
They're going to present to us whatever they do for Jefferson County. All their optional. Listen, I'm sorry. But what happens is all the finance have their conference. Holiday is always theirs. That way, our finance, our treasurers, well, actually, that's what I walked into. I walked into Berkeley County. All these you have so many. Like, you should have all this money. Overtime. I'm sorry. All these things. You need to talk about this. I don't so. That's when benefits was over in the finance department, and I moved it over to HR. And now benefits is an HR administrative reconciliation. Sorry, thank you for I think it's let me grab another one.
Yeah, we're also on the phone, but I just think
Okay.
I mean, it's really hard.
I'll call you after. We're supposed to meet.
I just think that it'd be hard.
I'm going to be right at 2 o'clock.
You could just give a couple of minutes.
Well, that's what happened.
Hey, Rob, are you on the phone, buddy? Is he there?
I am.
Actually, he can call the meeting to order. He can Rob, you got the agenda?
Oh, Rob,
I do, but Mr. Chairman, if you want to walk, since I was unable to make it, if you want to walk through and run the meeting, that'd be great with me.
Okay, I won't vote on anything, but I'll, bring things, and then you can. But Rob, you go ahead and talk on there now. We can hear you. We'll call the meeting to order, and Chairman will call for the approval of the minutes of the previous meeting. Is there a motion?
Make a motion to approve the minutes.
Okay, they've been moved and seconded. You ready to vote on it?
Yes.
All right, all in favor say aye.
Aye.
Opposed, the same. Okay, the minutes are approved. I see next on the agenda is Director Cheatham from PEIA to come up and talk about the things I think the last meeting we asked him to do in terms of quantifying the cost, and the committee was going to look at whether to recommend those changes or not.
Okay. Thank you. I have got, let me do this in some semblance of order. Here is a first handout for you. First thing I'd like to talk about is the flex plan that we talked about last week and the numbers. Thank you for. And then here are the numbers associated with that. Oh, give me the top one, please. I'm sorry, I didn't keep. No, I didn't keep. Yeah. Thanks. I just needed one. So this first grayish piece of paper basically is a list. I asked FBMC, our vendor, some of the reasons we don't have high participation, as you know, and that's what these are. And you can glance at those at your risk, at your own time, I mean. And then the second page is actually some of the numbers broken down. I was kind of curious, asking the questions: how much money is going in? What's the average contribution? What's going in by age? What's going in by salary? Kind of interesting data. You know, you've got a lot of people making less than $25,000 that are using medical FSA. And my only explanation to you, I hate to say this, is that goes back to the total family income issue. Because people have disposable income at that level that are contributing in there. But the big issue I think you'll see is that, you know, we just don't have a lot of participation. We have fairly low deductibles, fairly low out-of-pockets. 40-some+% of the people using the benefits anyway, so that's all the reasons that's a little low. So that was the first item on my agenda. The second item on my agenda was you'd asked me specifically, and here we go again with another handout. Jeff? Rob, did you get my documents I sent you?
I did, thank you.
Okay. Now I'm on the, what I'm talking about now is the three-tier exception on CVS. I was asked about what's going on with the third tier and the exception process. This is a breakout of the 3 tiers of drugs, as you can see: gross cost through what the member pays and how many unique members are using the drugs. Now, so you notice non-preferred brands, which is the third tier we've been discussing, that's 75% coinsurance. We have 7,812 unique users. If we were to grant an exception process for those users to be able to get back to brand, I had told you at the last meeting that with Humana, they have about a 30% approval rate on the appeal process. CVS's is actually 74%. That means 74%, 3 out of 4 drugs are moved to the preferred formulary under their exception process. And if you create an exception process and people find out about it, they'll be giving more third-tier drugs and trying to get exceptions for them and erode all the move we've made. I mean, we've got a 92% generic fill rate if you look at these unique utilizers and where they are. There's only 7,000 people that are in that third tier as it sits. Here's another exciting fact that is very hard to believe. I was surprised at the numbers, and I've asked them to rerun it. Of all the people at PEIA, so 142,000 unique users, only 518 users in plan year 18 hit their out-of-pocket maximum. And the out-of-pocket maximum, if you'll recall, is $1,750, which means 518 people paid $1,750 for drugs, plus a $75 deductible. And that's the worst anybody did. That's the worst anybody did. By the way, 487 of those 518, so 90-some% of them, were in the third tier. So 487 of these 7,812 people hit their out-of-pocket maximum, according to these statistics. I just wanted you to have that. So that was some data for you on that one. I'm ready to go to now what I call the out-of-state discussion. So again, some handouts. I'm going to the Blue Book documents, Rob.
Thank you.
Let me walk you through this real quick. We won't take a lot of time. I asked them to give us the update. They were finalizing the numbers for the plan year when we were meeting last time. So if you go to the first page, here's an example of how we do the max facility pricing. So what they do is they take all the rates for cataract surgery in the state and in our bordering counties outside. And those three color blocks, just to help you, the gray block is anesthesia. The blue block is the facility fee that does the service, and the green block is the physician fee. And so you'll notice in West Virginia, we have a pretty fixed fee for our physician fee schedules, as I told you already. So the green blocks are all about the same size. There is some variety in the facility fee blocks based on the type of facility, whether it's inpatient or outpatient or a critical access hospital or one of those issues. But you can see the rate, and then they draw a line down where they think the reasonable facility fee should be. Now take a look at the bordering county line down below, and you can see that some bordering counties charge over $9,000 for what we're saying should be a $2,000 procedure for a cataract surgery. But you'll notice out of state, there are also facilities in our bordering counties that will do it at these West Virginia rates. All we're asking to do with this maximum facility fee is to ask our members to shop. That's all we're asking, to shop. This gives you an example of that. So to the savings on the next page, here's 5 examples of max facility fees, what they were before we started the program, what they are after on average, and what the savings was by category. You can take a quick look at that. So someone asked me how about the savings is on the next page. I told you last year 3.6 million. That's stayed finished for the prior year. This is showing FY18 because this thing's been in place for 2 years. This is the second year. And somebody else also asked, how do you measure that savings? And I said some of it's redirected. How much is being moved back into West Virginia versus how much is being saved by being paid out of state at the lower rate. So that's broken out. So for the last plan year, it was about $9 million in savings. So if you flip over to the next page, you will see the total savings impact. The year one says $3 million. They came in at as I told you last time, at 3.6, about $3 million. And then year two is 9.6. So if you were to remove that, that is the impact you'd have for this piece. Now, it's up to $9 million. And if you look on the last page, our intention last year, but we were frozen, was to add another 75 procedures. Update 75 procedures and add another 27 procedures to the list, which we have not done because we were, quote, frozen, and I didn't want to make a change to impact our members at all while we were waiting. So there's still potential for more money and more procedures to be done. Any questions on the Healthcare Blue Book Max Facility Fee Program? Yes, sir.
Grab that microphone there since it's being streamed. And okay.
Thank you. Ted, on this first page, the cataract surgery example you're given here, the border counties, this is all border counties from all states, right?
No, this is our border counties.
Right, I understand.
Right,
but
right.
I mean, it's all the counties bordering West Virginia.
Yes, sir.
Okay, so that doesn't differentiate between the, say, counties in Kentucky and the counties in Virginia?
It does not on this chart at that level, but we could.
Okay. I'm guessing that there's a bimodal distribution there.
I don't know.
Okay. Okay, thanks.
All right. Next topic.
Hey, Ted, hold on.
Yes.
On the last page,
Yes.
and maybe I missed this, but so what do you mean by the 27 procedures added, recommended for addition? Does that mean there would become a maximum facility fee for 27 new procedures?
That's exactly right.
Okay.
And then there would be, we would update 75 procedures based on the new data and new rates everywhere, and some of those would actually go up, and some would go down. It depends on the rate. Would just be an update.
So, just do you, when you're looking at those, do you look at what facilities or providers we have in state that can do those versus out of state when you're determining what procedures to add or take or to refresh? Really just a question.
No. We believe that we would not add them if there were not adequacy within the state of West Virginia to get them done.
Okay. Thank you.
Mm-hmm. Next handout. Yeah. Here's one of these two, if you want to.
Yes, it does.
All right, so this one is to discuss what we've tried to manage is a rather complicated out-of-state coverage example for you. You'd ask questions about what are the deductibles and out-of-pockets out-of-state, and if they go back and forth, and if they're cross-applied or not. And I said typically no, out-of-state does not count towards in-state, but there are exceptions. All right. So what we've done, and it may be worth walking through. On the right-hand column, first understand it, I'll start over. First understand, if you leave the state of West Virginia and do not go to a contracted facility or go to a non-contracted facility, unless it's got approval, and the only way that would happen is if something seriously happened, like you needed burn care that you couldn't get in Huntington and Anderson and in Texas, we would approve that. They may be a non-contracted facility, and you would go there, and then you'd be covered at normal out-of-state benefits. That's a very rare exception. If you go to a non-contracted facility, except in emergencies, you are not covered at all, okay? And we're currently using the Aetna Signature Administrator Network, and in July 1st, we are moving to United's national network. So, the easiest one to talk about right now is in-state, and in-state we're at 80/20. And you can see an example of a cost at the $40,000 salary range of charges, discounts allowed, and how that would flow through. The second column is out of state, and that's with approval. If you go out of state with approval, it's 70/30 because that's our plan benefit. And you can see how that claim would be processed there and what the differences in the out-of-pocket would be for the member if they avail themselves. And these are physician fees, by the way, not hospital, just giving you an example. The third column says if you go out of state and you don't get approval where you needed approval, it's a lower level of benefit process at 60/40 instead of 70/30. And of course, the last column is you did go out of network with approval. That's emergency services, or if we have to send you somewhere we can't get it in the network. And I did want you to know about the deductible. As long as you're going With approval out of state or in state, deductibles and out-of-pocket maximums do transfer to each other. If you go out of state without approval, they do not, and they double. Excuse me. So you have, I just wanted to give you this example because we did talk about it, and it was a little more complicated than my simple response to you last time, and I wanted to make sure you understood that. Thank you very much. It's my livelihood. I just can't shake this stuff I've got. Rob, I'm now going to the task force proposals one-page sheet.
I'm with you.
You basically asked me what happens if we go back to 80-20, remove the maximum facility fee, and remove our $25 copay penalty for doing services out of state. And this is the cost of those broken down. I would just look in the total column for now just to give you a feel for what that is. We added Plan B because we have more and more people going to Plan B, and understand Plan B changed as well. We would put everything back to where it was, back to 80-20, back to 70-30. That cost to do that now, updated by the actuaries, $22.4 million. That's the cost. Now, you've picked the right year to try to do this, because below that, I would be remiss not telling you, we just went out to bid for our TPA services and awarded the contract to UMR, which is a subsidiary of United. Now, the admin is going up under that contract, but there is a cost-sharing discount guarantee that we believe, at the current estimate, will save about $12 million nationally by better out-of-state contract deals with United. Now, we may not hit that 12 million, and we could go up as high as 17 or 18 million. So it is, we've pegged it at a middle mark. It could be less and it could be more. Depends on what we actually realize in out-of-state discounts. This assumes we'll hit a 49% discount on the out-of-state bids, on the out-of-state claims. By the way, today we're at like 44. All right? So if you offset that, you can offset that cost. Yes, sir.
Related to that, okay, so that includes all of the agreements that you have presently, like with Cleveland Clinic and different things like that. Does that take into effect some of the proposals you're looking at here as well? With this, the one that you did before, where you were talking about out-of-state network with approval, without approval, with the contract you just got, does it have this involved in it as well?
Yes, it does.
Okay.
The rates would be lower out of state slightly.
Okay, so that's the reason for the little higher admin, with the idea of what you're going through with.
Right.
You could realize savings on that.
And by the way, on the bids, all of the bids had a higher admin than we're paying today. I mean, we haven't gone out to bid in 7, 8 years. So those admin rates were held and they were stale.
All right, thanks.
So Ted, a claimant goes out of network without approval. Under the new scenario, currently you're using the Aetna signature network to help drive that cost down. Under the new proposals, it's UMR coming in, and that's what you're using to negotiate the facility fee.
Yes.
Okay.
Well, the facility fee is set by Blue Book based on claims data. Okay. What we would do is we would use the United fee schedule for all the facilities out there, and if the max facility applied, the balance would be up to the United fee schedule instead of up to the Aetna fee schedule.
Gotcha.
Right?
Okay.
So I know this isn't the cost committee, this is the benefit committee. But as I tell my finance board all the time, you cannot work in a vacuum. Costs are completely related to benefits. So I'm showing you a $22 million increase to do the things you proposed to me last time. I'm saying I believe I can offset some of that increase because of the new bid that's going into effect July 1st to try to help. But that still leaves you a $9 million deficit. But I want to show you what's important about what this means to the finance plan of PEIA. So now I'm going to talk to you about the finance plan.
Ed, real quick, looking at this out-of-state coverage, this claim example,
Yes.
right? Have we ever showed any of the participants anything like this to compare a claim, how it would work through the different structures?
We have a, online, we have a summary of benefit comparison that's required by the ACA that is a live interactive model that they can put in data and see how it would impact their claims. But, you know, we could indeed put some stuff online and talk about this.
I mean, because my point is, when we see this all the time, we talk about the education of benefits, that if it's a higher educated person, they're going to get more out of their benefits, right? It's a pretty simple correlation. You know, the more you know, the better you use it. I think that'd be pretty powerful, getting one beginning step in getting people to realize the cost difference between choosing in-state versus out-of-state if they have that opportunity, right? And I understand that there may not be that opportunity.
Unfortunately, it doesn't work that way, because I have quite a few educated employees who come to talk to me about this, and they completely understand the nuts and bolts of it. Very intelligent individuals, and
Sure.
the cost is still, but they still want the border situation resolved.
Well, no. I'm not discounting that at all. I understand that there's a provider issue, and I understand the cost. I get what you're saying, but I'm saying take it more internally to the state too. I'm saying if people would kind of, because everybody says, well, I'll just go to Cleveland Clinic, and it's a big cost savings. No, I'm not discounting the provider issue. I just wanted to make a comment that this is a pretty telling slide, and
I think it's, I mean, I agree. I definitely think it's informative, but I don't feel like there would be it wouldn't have any significant impact on them, unfortunately.
Rob, I'm on the financial plan, scenario 1.
Can I ask, just so I understand what you were talking about, in terms of why it would not work, is because they go to that facility for most every kind of, they're the closest facility and easiest for them to get to, and they use it for most every procedure?
It's, there's many reasons behind it. You know, for one example, there are, lack of resources in the Panhandle, so they will go to the other facilities outside of the state. You're talking about employees who've, worked several years, especially when resources were not available, and they've established these relationships with these providers, and have had
So define
serious.
what lack of resources is, to make sure I understand. Just their monetary?
No, just providers. So a 6-month waiting period for.
That's why I'm trying to make sure I understood.
The waiting periods.
That's the way I
it could,
what she was saying.
Or, and the example that I gave early on is that, we had one employee who was in a serious accident, and the emergency personnel on the scene, the closest hospital was Winchester, Winchester. So that's where that patient had to go, and
They didn't have a choice.
that's what
I understand that, and see, that's so much different from a border area that I'm in, totally different, so that's why I wanted to understand this, exactly
Right.
Okay.
Right, no, it's very multifaceted and extremely complicated, but from our perspective, but it is a resource, especially, Ted did confirm that the last couple of sessions, that there is a resource concern.
Just making sure I understood.
No, and I appreciate the opportunity to clarify. Thank you.
Okay, so PEI scenario 1 with task force proposal is what it says. This financial proposal assumes we adopt these proposals that I gave you in the last page, this $22.4 million change. So let me just pay attention, if you would. Let's walk down 2020, which is the plan year we're trying to address. That begins in July 1st of 19. You see at the top, there's no additional employer premium. There's no additional employee premium because, again, we've said to you, we've built enough extra money last year to be able to hold it over for a year without you. But if you'll go down into the under the, next to the bottom, it says State Fund box, the big bold box, it says State Fund. And you look across to 2020, you'll see that we're, quote, losing or spending our excess balance of money that we have to the tune of $51 million. And you remember my mantra? Every year we need an additional $51 million. There it is. There's the $51 million that we need. I'm telling you that we've got it in the bank because we had such a great year last year. So we'll be able to cover that for you this year. And you notice that takes us down to our statutory reserve, which is 14%. So we've spent down, I mean, we're on the line. If you'd have come back to me with higher, wanting more in the plan, I would have to ask you for money. We're on the edge here. But we could accommodate that change, okay? Now, if you look at 2021, here's where the fund starts. Look at what I'm going to need for employer premium in 2021. I need $102 million. Governor Justice pledged to give us $100 million in PEIA. Well, guess what? I'm going to spend it in 2021. And how did we get to $100 million? Because I know somebody's going to ask me, and it's pretty simple math, right? I need $50 million, and I lost $50 million. You got to give me the $50 million I spent out of my pocket last year on the loss to make up the loss, and a new $50 million. That's the $100 million. You notice that also generates, in an election year, a $25 million premium increase for the employees. I just wanted to show that to you so you know where we go. And I'm not really too concerned about the out years, but you can look at the out years and see my additional $50 million every year. Let me hand you out the next one. Rob, I'm looking at scenario 2.
Okay.
By the way, we're not going to say anything. We're going to let them decide, and then we'll run this by the governor.
All right, so we'll walk down the same 2020 column. A couple of changes here is we did not make the changes proposed by the task force. We implemented those new 27 max facility fees and got some planned savings for some of those results. As a result, if you look down into that state fund box, you'll see that we only took a loss of $35 million and kept a little bit of reserve to spend the next year. Because if you go to 2021, you'll notice instead of $102 million, we're now down to $73 million. And if you look down at the state fund box, you'll see we're still taking a slight loss because we still got some excess money to spend to get us down to the reserve of 14%. So I want you to be aware of the impact of a $20 million give back and what that means to you over the course of 2, 3, 4, 5 years. Because that $20 million in spend will also trend at 5 to 6% a year going forward. So I just, this is exactly how I explain this when I go out to public hearings. So there's my presentation for the day.
I'm just going to speak for the chairman of this committee and just say that it would now be up to you guys to discuss, you know, whether you want to take action on these proposals or not this session or not. So he's laid out 2 scenarios. There could be hybrids, I'm sure. But anyway, so it's up to you all to discuss it, and I'll recognize people who want to talk. Rob, I'll recognize them for you since you can't see them. Does anybody have any comments on what you want to do? What you want to recommend to the full committee?
Go for it.
Okay.
I just want to start by, talking it out first before we decide which way we want to go.
Okay.
But, I completely understand the numbers. I think that we see a clear picture of the financial aspects of it. I do know, too, that it was made crystal clear in the listening sessions across the state that the out-of-state coverage is one of the leading concerns that the members had, and it's not just the Eastern Panhandle, it's across the state. In addition to the listening sessions, I received back from the West Virginia School Human Resource Officials Association, where the border coverage for all the counties present also recognize this as an issue. So it's my recommendation for this committee that we make a motion, or discuss, or make a motion to move. Can we do that? Or to discuss it?
As a member of the committee, you have a right to make a motion. If it's seconded, then it can be, discussed and acted upon.
Okay. Do you guys want to discuss it, or do you want me to make a motion? To move the out-of-state coverage to the full committee for going back to the way that it was, 80-20.
Which would be scenario one, is that correct?
That's correct.
So she's moving that committee adopts scenario one. Rob, I'm telling you, so you, the chairman, can note.
For ease of you're moving, we adopt this page. Is that correct?
I think because we need to discuss it with the
Yes.
board, right?
This page is reflected in scenario one.
This is scenario one, yes.
Okay.
Just make it easy for you to.
Right.
And everything back to the way that it was. Right.
Is there a second?
Huh? Can or can't?
He can't.
Oh, you're not?
Can't.
Well, Mr. Chairman, I don't hear a second.
Sure, if I might ask a question of Director Jeter before we make a decision on this motion. Ted, as I understand the documents here, scenario one and scenario two, scenario one is the numbers as they either are or would be or are projected to be if we implement what we'll call this page that you're talking about.
Yes, sir.
And scenario two is the numbers as they are or we'd expect them to be without that, but with the implementation of the cost savings from the 27 additional procedures that you mentioned in your earlier part of your presentation.
Yes, sir.
And the plan has not proceeded with the cost savings for those 27 procedures.
Well, let me clarify.
Okay.
I'm sorry. I did mention the 27 procedures. That's really not the bulk of this. The bulk of this is we'll get the full effect of our out-of-state discounts, because right now we're offsetting those out-of-state discounts. That $12 million we're applying towards you in scenario one to offset the $20 million expense. If we don't do that, we'll net that $12 million savings from the new TPA contract here. That $9 million reflects the state share of that, in that most of it is coming from the out-of-state savings.
Okay, so am I correct to say that there could be a scenario three where we do implement the savings and pursue the out-of-state proposal that would result in some hybrid?
There is. The 27 additional procedures and the changes, I don't think you'll see that significant of a savings off of those.
Do not think
I do
that.
not.
Okay.
The big difference in the two scenarios is the fact that if you look on this chart here, you notice you're voting for a $22 million spend, and we're offsetting that with what's called a medical savings in the network discount of $12 million.
Okay.
If you didn't, so the net result is we've got an additional cost of $9 million. You can see that?
I do.
Yeah, we would not have a cost of $9 million if we didn't adopt the top. We'd actually be able to add $12 million more in savings.
Okay.
So,
Yeah, we get the full $12 million put towards a positive to us instead of an offset to the expense. That's the big difference. That's the big difference.
Okay, that's helpful. Thank you.
Yes.
I'm sorry, Roger, Mr. Speaker, were you done?
I am. Thank you, Rob. Yes.
The scenario 2, Ted, without the task force proposal, let's just take 2020 for an example. Does that take into account, are the medical savings and the additional admin costs that you think you're going to get with these new network savings, are they embedded in the scenario 2?
Yes.
Okay, so even with those savings, make sure I'm looking at this right. Even with those savings in 2020, you're looking at a $35 million burn rate for the trust, or for the reserve, I'm sorry.
Yes.
35.5?
Yes.
Okay.
Could I? Okay. As I see this and everything, I think it's very important that we know where the governor's office is on this, because I would really not like to take an action here without vetting this in some way with the governor's office, and you know, to have. I think that the other thing is once you do this, then what does this affect as it goes forward? So, you know, I would prefer not taking action at this meeting and defer this to another one and having some discussions with the governor's office related to this to see how that affects the money that's coming in or what's going to be put in the overall plan.
Can I ask a question?
Yes, I'll act as a proxy for the chairman, and you can ask a question. Rob, she's going to ask a question.
Do you know, is there any information from the governor's office regarding
Well,
the
this is
of the border?
Well, this is the first time that this concrete of information has been, that I've seen it. I mean, I, could have speculated on it, but at this point, I do feel like I need to take it back down and let the director come and speak to people in the office and see if there is guidance. Although when we set up the task force, we did know the assumption was that you all would have some authority to act on your own initiative.
Exactly.
But probably that would be, I think, would be the better part of wisdom to at least inform the governor where your committee is.
Okay.
And without, in my opinion, overriding what you choose to do. But I think information at this point would kind of be important, so that it might be a prudent thing to give us a couple days to digest this and see what his opinion is.
Okay. I'll withdraw the motion then, and then I do have a question for you, Ted. Looking at the out-of-state.
Withdraw the motion with the idea that we take it up at the next one.
Okay.
The next meeting is what I would prefer us doing.
Okay.
Yeah,
Okay.
that's fair.
Okay, that's fine with me. The out-of-state coverage example.
Yes.
The second column, out-of-state and network with approval. This, if I'm correct, this is the column that's kind of causing the most concern. Is that correct?
Yes.
Okay. So if we change just this column to 80/20, and we adjusted the allowed and the discount, and then the 80% with the plan payment, and adjust the share and the out-of-pocket maximum, given in mind that you mentioned that this would cover most concerns, would that alleviate some of the financial burden and requirements to have the plan change to go back to the way that it was?
I'm not sure I quite understand your question. The charged and the discount amounts are what we currently have under contract. So all that would change would be so the allowed amount will remain the same. What would change is the planned payment at 70% would go to 80%, and if I'll get my
Right,
phone
that
out.
would shift it then.
That's what she's
Yeah,
referring to.
That's what would happen.
Yeah, that's what I'm
And that's
referring to.
exactly what's reflected in the financial plan, is that we change that to 80/20. And of course, Yes.
But does the financial plan also take into account the last two columns?
Yes, those would not change.
In your
the last column would also change to 80/20.
But, okay. But what if we just change the second column? Would that?
Well, I would suggest if you're going to change the second column, you really should change the third column, because that's the scenario you've got where somebody's in an emergency room going to a place that was not contracted. And you'd want them at 80/20 as well, I would think.
All right.
We, even before, when we were still at 80/20, the penalty for not complying was always 60/40. And I would suggest we leave that third column alone, even if you wanted to do that. That's what this assumes, I believe.
Okay.
That we changing the second and the fourth column.
Okay. I just wanted to see if there was
Do
like
you want me to do the math
hybrid.
to see what the difference is for you?
Yeah.
So,
I think what we're all talking about here, and it just kind of, I think we're kind of going around it, is that, you know, yeah, we've got the issues on these bordering counties, but what I'm hearing more and more is it's a provider, lack of providers. So
yeah.
it's a lack, and so I'm curious as to, Ted, can we do any type of network analysis to see where those pain points are? Does that make sense?
Sure it does.
Can Blue Book do that on
Sure.
our bordering? Because
that's
you
necessary.
made the comment, sir, that it's not as much of a concern in your area.
Right.
I'm feeling like it's more of a concern in the
It would be.
eastern kind of, the panhandle down through, especially when you get down
northern
into, right.
Yeah.
So, and again, what I'm hearing, as why I think that we're gaining some traction there with more providers through different outlets, it's just not there yet, and the growth is exceeding the demand.
Correct. That's correct.
That's a new problem to come, I mean, it really is.
Well, that's one, that's one of the reasons why I thought we need to analyze this a little more and get some feedback from the governor's office as they have looked at it, and you have informed them. But I do think there's some other scenarios that we may want to review in that, and I think you bring up a great point as it relates to that. I would say I talk about the geographic area that I represent, but I also think most of the other border areas are in a similar situation as we are in the Huntington area, absent of what's the issue. And I think bringing it up as more of a growth problem and not enough providers, I never had really thought about it that way, and I think that makes a lot of sense to try to address it.
I think that I would agree wholeheartedly that the Eastern Panhandle is a very unique issue. We have tried to fit one peg into all the holes, and it doesn't fit well in the Eastern Panhandle. I don't fault you. I'm not in here saying we should or shouldn't do this at all, because I understand the problem exactly, and they are indeed unique. Geography-wise, a lot of people are coming out of those foothills having to get care out of state, all the way halfway down the state of West Virginia. And many of those people are having to drive by Winchester Hospital to get to City Hospital. And it's another 20 minutes up the road. I've got it. Maybe the compromise here, and it starts to get more and more difficult to administer, and when do we open that door? But maybe the answer is the Eastern Panhandle moves to 80/20 as a separate plan design that you don't need to do in Huntington, you don't need to do in Parkersburg, you don't need to do in, you might need to do it in Weirton.
I understand that.
But maybe not into Pittsburgh, across the border. So, I'm talking out loud. I understand the pain of that area a lot.
Greater reason to have more conversations, and let's concentrate that down with the governor's office to look at those scenarios and come with some consensus to come back to the committee the next time.
Yeah, I think we need some provider data. I'd really love to have some type of benchmark of how short we are on providers and facilities in that area. And I know the data's out there when we have different ways of getting it.
Right. Do you want me to run this through the Aetna network, or do you want me to run this through United Network, or both? I mean, We're contracted. The issue is,
Moving forward with a new one in July, might as well look at UHC. not-
yeah, right, okay.
It would include specialists too, correct?
Right,
Any type of
So
profession.
facilities, specialists, primary, I mean, the whole,
Right.
I mean, I think we need to look at everything.
Right.
Even, yeah.
Well, let me qualify your request. I understand what you're asking for, but what's the data going to tell you? Because we're contracted in the bordering counties with almost everybody. If they're not there, just you counting them and saying, I'm missing a cardiac thoracic surgeon in Winchester's not going to help me because I'm not going to be able to get one.
Right.
See what I mean? I don't know if I'm not saying no, I'm here to serve. Don't know that we're going to gain any data out of it. We're contracted with most of the doctors that are sitting over there. And if we've got a shortage of physicians, it's not because we haven't been able to contract with them.
Right, well, how short are we on the population demand? Is that
I understand the question, and we can probably do some, actually, I think the state of, well, we can probably do some analysis on that. But again, can you impact it? What are you going to do about it? I mean, we're going to get data, but are we spending resources to not be able to impact it?
I don't see you moving the provider needle quickly, you know
Right,
that. Right.
right.
I understand where you're coming from.
So let me ask a question. Could you do a pilot project to do this for 1 year and do the analysis? Or for 2 years and do the analysis, and after 1 year, you're going to have a better idea of where things are and whether this actually addressed the issue?
The pilot being?
To 80/20, it's suggested.
I would, you mean just for that one area?
Yes, yeah.
Well, I don't know if, again, we could. I don't know that it.
We've never done that, and we want to be fair to every area, but I do think there are some unique challenges related to this, particularly because of growth, population growth.
Yeah, no, I understand. I would suggest to you, if you want to do it, we know what the impacts, we can figure out what the impact would be of just doing that area. There's really not a need to do a pilot and do the cost analysis. We can figure that out, and
Okay.
we'll be
All
close.
right.
And then, and I don't mind at all, but be careful about the walking down the door as do we add Hagerstown, Maryland in, which is north of the Panhandle? Do we add Cumberland across the border from Cumberland, Maryland is another spot that bubbles?
Right, that was one that brought up an area, Cumberland.
Yeah, Cumberland, yes. I'll give them all to you. Cumberland, Hagerstown, Winchester. Those are all areas surrounding West Virginia that we bubble with. And as a matter of fact, West Virginia University's got clinics across the border in Hagerstown, I think.
Ohio County.
No?
Provider.
Yeah. Yeah.
You know of any other areas? Any other areas on the border?
Harrisonburg would be another. Yeah, down south, Harrisonburg, yep, of course.
Carillion.
Yeah, we got a lot of it, yeah.
Carillion, which is Roanoke, right?
What one?
Carillion and Roanoke.
You also go to UVA, yeah,
No,
that's Cumberland.
and I think what you
You know, you
start going, right?
Right, and that's all I'm trying to say to you. You've now taken the whole, from the Eastern Panhandle all the way down south into Covington, Virginia, right? Which I don't mind, it just seems like we're better off. Then we get to the point of, are we better off just to go to 80/20? Because again, does somebody in Parkersburg now start complaining?
No,
Somebody in Weirton wants to complain about not being able to go across the river at 80/20. I mean, can't go to Pittsburgh at 80/20, that's the next one.
Go back to,
So, I think what we're all saying, I think
pilot the process.
Ted can give us the cost based on claim scenario. He's got the data. You got the data to give us the costs on that.
Do you understand that Winchester,
What's that?
Winchester Hospital, I looked at the state, and I don't want to tell you wrong. It's either number 1 or number 2, followed by Cleveland Clinic, of our spend.
Of your spend.
Of our spend. Of our out-of-state spend, Winchester's number 1 or 2.
And let me just remind everybody that's another scenario with that is that Valley Health owns the hospital in Morgan County. So if they start there and they're triaged, they're going to be triaged out of the state. So that's out of their control. So that's a scenario that's real.
That's correct.
So I apologize, I couldn't hear that last point.
A good point.
Just to remind that, you know, one of the reasons why Winchester costs are heavy there is that the hospital in Morgan County is owned by Valley Health. So if they start there and they're triaged to the next level of service or they don't have resources, then they're being triaged to Winchester. So that's a component of that cost structure.
I can't believe you're bringing reality into this.
I'm in full agreement with your assessment. I really am. I understand all those issues, and you've got an extremely valid point. All I wanted to share, because you asked me, was what does it cost to do it? I'm not adverse to doing it at all. I just want to know what it costs to do it. And that's the decision that needs to be made.
Right, and that's important because that's what we need to know is what the costs are. And I think that's, you know, goes back to my, you know, first point was that we're at a crossroads to knowing that this is what the members want, but this is the cost associated with, and I agree with having that conversation with the governor because that's where we're at. This is where I think it all falls on,
Right.
to be honest with
and
you.
ultimately,
this is
you know, when we ask ourselves the question, how did we get here in the first place? Ultimately, we got here because of the budget that we were given, and we had to cut some benefits, and it was a state financial issue that drove us here in the first place. And even if we get to 80-20 again, that doesn't mean in 5 or 6 years we're not going to run into a financial crisis and take it back to 70-30 because of the need.
That's again another central part of the, you know, the problem is that it's going to continue to cost and it's going to increase, and where do we fall on that? It's you know, continuing to take care of our members and our employees. And as you know, I think a couple of meetings ago somebody asked what the philosophical direction and question was, and I think that's really what it comes down to for, you know, anybody sitting here and anybody who's listening in decision-making positions or who is looking into becoming into decision-making positions is that this question is going to be ongoing, and it's important that we decide or think and look at where we're headed, where we're going, and what financial support do we want to provide.
The other, you know, I know I'm not here to be on the committee or anything, but you know, another thought process here, if you want to look at it, we could consider, I guess, looking at just raising the bordering counties to 80-20.
Right.
And if you just move the bordering counties to 80-20, then Cleveland Clinic would stay at 70-30, UPMC would stay at 70-30, UVA would stay at 70-30, Duke would stay at 70-30. And that would cut down on some of this spend as a compromise on money. You know, we asked for a hybrid. There's a potential hybrid. Again, a little harder to administer, but we can figure it out.
I'm going to speak for the chairman. Is there more discussion about any other matter? What we intend to do, we've been looking in the 2 or 3 weeks out. We know the report's due to the interim committee in December. I think it's 10, 11, 12. So we're looking at that week prior to kind of have this committee's work done and then the cost committee's work done, and you know, and Then the full committee meet that week and put the recommendation together. We've already cleared it with the person that's going to write it all, and she says she can work with that time frame. And obviously, we're running into Thanksgiving holidays and different things, so that's, you know, this committee can meet before that, by the way. I mean, you don't have to, you know, you can decide, and we'll work on that to hear it. And what I'll do is we'll have the director come and meet with the governor's office and the governor probably himself and just go over even that last scenario you brought up. You know, you can just, you know, bring everything and say, here are some items, possible compromises, possible solutions or whatever, and bring them back to you. And get them to you prior to the meeting, by the way, so that you'll see them. I assume all your emails are available, and, you know, we can get that all out to you. I think probably it's been pretty clear to me anyway. It's been pretty clear to the committee what, you know, how this decision is coming, where it's coming to, and what the implications are. So you've seen probably both extremes, haven't you, in scenario 1 and 2. Scenario 1's probably the most expensive. Scenario 2 is actually taking those 27 procedures, and it's actually going forward with something that isn't real now. Is that correct?
Right.
So that would be and then somewhere in the middle could be the recommendation. But any questions about what appears to be the continuum of decision here? Yeah.
One more we didn't discuss, drug coverage.
All right, go ahead.
I think we need to have that cost at the next discussion as well, correct?
I provided that to you?
This today?
Yes. The bottom line is that if you wanted to put that pre-cert in place, that's about just under $2 million cost.
Did you put that in scenario 2?
No, it's not in any of the scenarios.
Okay.
And it's the CVS handout.
Do we need it as a scenario?
First or second right here.
We need it as a scenario?
This one right here.
So what you were saying on this, Ted, just to recap on the
Oh, yeah,
CVS
sorry.
has a 74% exception rate?
They do. And this model assumes 100% just so you see what the whole cost is.
So that's from non-preferred to preferred is what you're saying. That's
Yes.
the exception. So we're all
Yes.
clear on what that is and the cost difference with that.
Yes.
Okay.
Because it would go to a $25 copay as opposed to 75% coinsurance.
Of that in 2018, you're saying 518 people met the 1750 max RX out
Yes.
of pocket.
According to the data I just
The
got.
only way to meet that max, so everybody knows, is by copays or co-insurance share, right? Okay? So, and of those who met the max, 487 of them were in that third tier, which is the non-preferred brand name drugs.
That's correct.
Okay.
Most of them were in the third tier.
And the one thing that Jeff and I were discussing before we started that forgot to bring up the last time was one of the concerns was the mandated 90-day supply.
Yes.
And would that affect
It would
this
change.
number?
This is, the 90-day mandate is easily in the $12 million range.
Okay, so 90-day mandate, 12 million.
And please don't forget, the 90-day fill, I know there are odd circumstances. You talked about inhalers the other day, so I remember that. The 90-day is a cash flow issue for some people. But understand that the 90-day is actually cheaper for the member as well. They're paying 2 copays instead of 3. So if they're on a middle-tier drug, they're saving $25 every 90-day supply. It may be a cash flow issue, but if you can get through that side of it, it is actually cheaper to go to a 90-day fill. It not only saves the plan money, and we've seen a substantial amount of money, like I said, under this 90-day fill, and the member saves as well. I mean, this really is, I hate to say this, it should be a win-win.
Okay.
And I do understand there's some low-end people that are taking a lot of drugs and have difficulty meeting those copays.
What about the burden on the local pharmacist?
What burden on the local pharmacist?
The ones that they discussed at the listening sessions. We had a handful of local pharmacists speak and also submit.
Oh, sure.
their-
Oh, no, I've got you. Yeah, no, I've got
Okay.
you. So.
Do you have any suggestions for that?
Yeah, so here, let's walk through the drug delivery system for just a second. Somebody's paying for every piece of the drug. Somebody's got to dispense it. Somebody's got to buy it. And somebody's got to pay for it. And how we divvy up those cost shares is the way to go. What we've done in the state of West Virginia on this contract is we have the potential to save the state of West Virginia $2 to $3 million at least. It may be more. I haven't run it in a couple of years, by mandating mail order. We've taken the approach at PEIA that our mom and pop pharmacies are more important than that $2 to $3 million, and have then signed contracts with people to do what's called a 90-day retail fill, which is the same as mail order. And the rate is identical to mail order as it is today. However, if I went to straight mail order, I know I could get another 2 points easy off the discount rate. So are the pharmacists being squeezed on a 90-day supply? Yes, they are. But somebody's got to, if you want to I gave you $12 million savings to the state. Somebody has to pay for that $12 million savings somehow. In this case, I think a lot of it was the pharmacies, because we got a better discount on drugs. Chief Hall will know I brought him another option for drugs, to go to a spread contract. It would save another $2 to $3 million. Who would pay for that? The pharmacies, the mom and pops. And the chief aptly said, living next door to the fruit guy, it's a bad idea for our mom and pop pharmacies. So we did not execute. I'm just, I'm always looking at ways to save money. And when you save money, it's coming from somewhere. I think the 90-day fill does squeeze some pharmacies, especially on insulin. We found that to be one of them. But it should be good for the state, and it should be good for the member.
That's it. I'm good.
Is there any other questions or comments, discussion that you want to bring up? I think that last one was real important to look at. All right, Mr. Chairman, on the phone there, do you have any comments you want to make before I ask for your committee to adjourn? Is Rob there?
No, yeah, I'm here. Do you want to, I guess, to the committee members, perhaps maybe the Monday or Tuesday after the Thanksgiving, when we can get another meeting scheduled, we'll work on getting the next meeting scheduled to continue this dialogue.
That's the 27th, right? Yeah. 26th. Okay.
Yeah, we'll talk about that. Either that week or the next week, but you can do it that week.
That week. Later in
Okay. All right. We want to, okay, then, Mr. Chairman, do you want to obtain a motion that they adjourn?
Can I ask before you adjourn?
Yes.
Do I have a deliverable for anyone on this committee? I will look at the 80-20 in the bordering counties. That's my one takeaway that we'll take a look at, see what that cost change would be. But any other takeaways for me, any requests for me?
Yeah, I mean, we'll get that information too, and we'll tend to have, since the question was asked about the governor's office, at least understanding, you all still have the initiative, maybe authority to act, take the initiative to act with that authority, but we will obviously run this by folks in our office too, so everybody understands what's being done. Because, the public's very interested in this. It's obvious that there's, we don't want to be misunderstood, really be very transparent and let people be very well aware of what, I think this has been probably some of the most concrete information that actually puts meat on the bones and says, this is what you heard in those public hearings in terms of border drug issues. This is now the way you fix that, to use that word we haven't used in a long time. But here's the cost of that. And he's giving you a 5-year projection. So then it's up to us as a state and a task force and legislature and everybody else who will be able to have an impact on this decision to make it going forward. So, Mr. Chairman, do you want me to ask for them to move to adjourn?
You sound like the guy that sits next to me.
Yeah, I know.
Here.
But since I don't have a vote, I was going to let. Okay, I think he wants somebody to move to adjourn.
I move to adjourn.
Second.
All right, all in favor say aye.